Welcome to Follow the Medical Record, where healthcare experts give insights into the increasing importance of following a patient's medical record through the health ecosystem with compliance, privacy, security, and efficiency front and center. This podcast is brought to you by MRO and hosted by Don Hardwick, Senior Vice President of Client Relations at MRO. Don has been in the health information management industry for over 40 years and has extensive knowledge of how medical records make their way through the healthcare ecosystem. At MRO, Don is responsible for strategic client engagement programs and overall client satisfaction. To hear from all of MRO's industry experts, be sure to visit mrocorp.com for additional content and to sign up for our monthly e-newsletter. Over to you, Don.
Hello, everyone. I'm your host, Don Hardwick, and I want to thank you for listening to our debut episode of Follow the Medical Record. We started this podcast to share thought leadership with the healthcare community. You can learn more about me and my background on mrocorp.com and can connect with me on LinkedIn. And be sure to follow us on Twitter at mrocorp. My very first guest, I had looked no further than our own Rita Bowen, here today to talk about HHS proposal rule modifying the Hipaa Privacy Act, a big topic of conversation in the industry right now. Rita is the Vice President of Privacy, Compliance, and Health Information Management Policy for MRO and a national speaker and author on all things HIM related. So welcome, Rita.
Thank you, Don.
I appreciate your time and willingness to explain to the audience a little bit about the HIPAA privacy rule that has come out in response to some conditions that are facing the medical industry right now when it comes to confidentiality and privacy of patient information. So there is a proposed rule that is out called the Notice of Proposed Rule Making and Modifications that center around the HIPAA privacy rule that's being proposed. So if you can, Rita, explain to the audience what's precipitated this change or update, and what are the changes that are being made with this rule?
Surely, Don, that's a good segue into this process. Let's face it, HIPAA was originally designed under President Bill Clinton. So it was 1996 when this rule was designed. And as you think of 1996 and think of today, the delivery of healthcare is totally different. So there's many components of the way information could be shared that didn't exist in 1996. However, there's a lot of the information in the Notice of Proposed Rulemaking that many of us believe should not be thrown away. So as we all know, HIPAA became effective for privacy in 2003 and for security in 2005, and people have gotten very comfortable with that. They know those rules. They understand that process. So rather than throwing everything out and beginning anew, it is suggested that the rule be reevaluated and harmonized to work more in alignment with interoperability, the high-tech rule, and have commonality among definitions between the various rules. If the Notice of Proposed Rulemaking were to go into effect as written, it would actually introduce some conflicts of definition and which one would take precedence. So MRO is working diligently on their response. HIOS, as Don mentioned earlier, is the Association for All Outsourced Vendors. We're working, HEMA is working on that. There's also a group called the Confidentiality Coalition that I just recently joined, and they also will be preparing a response. They all will not mirror exactly, the same comments, but some of the same concerns are there. And in that, some of the concerns lie that the current guardrails that sort of guard privacy for a patient are basically falling away. And what I mean by that, if a patient wants to take control of their information and say they want to direct that information to an app, the app can be taking that information and loading it, and it actually may be going into another country. It might be China, it might be Russia, and then there's nothing that predicates what that company can or can't do with that information once they have it. So there should be some guardrail for any non-natural third party that's going to be obtaining the information if it's not solely for the use of the patient's healthcare or healthcare coordination. But if you haven't read the rule, I encourage you to do that. MRO will be next week, which on the 17th, a colleague, Angela Rose, and myself will be providing a webinar just on that topic. And you could always ask for the slides and the audio if you were not able to participate in that.
So, Rita, the guardrails for privacy and confidentiality have been in effect since 1996, as you mentioned, when Hipaa first came out. And there were certain standards that had to be followed, one of which was having a written request from a patient so that the patient was informed under most of these conditions as to who was going to access their record. If these guardrails are being diminished on behalf of the patient today under this proposed rule, how does the facility, or how can there be an assurance to the patient population that certain standards are still going to be upheld?
That's a good question, Don. That's why, as you're reading this rule, and if you tie it back to other components, especially ONC's final rule on interoperability and information blocking, and then tie it to CMS's final rule on interoperability and that process, you need to highlight where they have differing definitions and different interpretations, because that's going to lead to confusion in the industry. So that should be part of what you call out in your response to HHS on this notice of proposed rulemaking. Part of the concern is the fact that one of the things that the notice of proposed rulemaking suggests is that the patient may not have, they don't want any barriers for the patient. And I think we would all agree there should not be any barrier for a patient to receive their information. But it says the facility may take a verbal request. Now, if I'm coming to you and Don, you're at the hospital and I say, hi, and I'm Rita Bowen, and you can look at my record, you look at you know who I am. I can give you that verbal request. But if I'm calling on the phone and I try to give you a verbal request, how do you know it's me? So that's a question, a process, and it really puts a burden back on the facility as to how they're going to operationalize that. So in MRO's response, we're going to respond that is a concern to us. And if by chance they want to leave that in the rule as it goes forward, we are going to submit a best practice of what we think would be best practice for validation. And we're asking that become part of the preamble of the rule if it is to be released with that content in there. But without some kind of a guidance, it's a free-for-all. There's nothing currently that provides guidance on a verbal authorization because it doesn't exist right now.
I can see that this would facilitate for the patient population, and I'm a consumer as well as you. And so it would seem that's a step in the right direction, that we would be able to come into a facility, ask for our information, receive our information without having to fill out a lot of additional documentation. So that seems like a good solution here for accessibility and reducing any of those barriers. I think you do bring up a good point, is that there has been a shift in the technology use and being able to accurately identify that I'm a consumer and the correct consumer when I'm asking for my records via internet capability, or being able to submit my request through some kind of electronic means and then be able to receive those in an electronic means so that I get my information quickly. Most of the time, it seems like that patients, when they want their information, they want it quickly. Has this
Correct.
rule proposal improved any of that demand or timeline that is associated with receiving that information or the facility providing that information?
It has, Don. What they are proposing in this notice proposed rulemaking is taking the standard, the current standard of response of 30 days, with allowing a one-time 30-day extension, reducing that to 15 days for response to the patient, and with one 15-day extension if necessary. And for the most part, I don't think that will present a problem for many, but I do believe that for some smaller facilities, critical access facilities, rural practices, that it may pose a problem. So I think that they need to take into account that it needs to have a little cushion there and maybe not be so dogmatic with fines that could be imposed upon that, as long as the facility is making reasonable efforts to respond to that patient as quickly as possible. So I don't know if they really need to change it to 15 days. MRO is not going to oppose that. It's not the hill we want to die on for this perspective, because we can turn information around in that period of time. But for some facilities, we think it could pose a problem. And as you review the 16 cases that the Office of Civil Rights has over the last 2 years issued on patient access penalties, they have dealt with delays, and some quite serious. And I think that needs to be looked at as to what's causing those. And the root cause, when you get into many of that, it's either one, lack of understanding, which, maybe a smaller facility doesn't have the staff for the staff training that they may need to respond appropriately for release of information. The other component could be that they have so many disparate systems that it's hard to collate all of that information, to pull it all together. Or they're trying to work this information, but the outlying practices or clinics are actually imaging in requests as they come through, and they may get behind in doing that, so that the central repository that's trying to respond to the request gets it already late. And that may cause the problem too. So there's a lot of root cause analysis that needs to be evaluated there. But that has been a suggestion that there is a need to get that information quicker to the patient. But now keep in mind that the interoperability rule, which the applicability date for that is April the 5th of this year, will require that information is pushing, and it's the identified core elements, the USCDI elements that are considered the core elements that should go with the patient, no matter what level of care they're moving to or moving from, should follow the patient. Those are supposed to be pushed to the patient portal so that the patient can obtain that information without any special effort at any time that they want to. So as patients become more comfortable in using their portal and feel comfortable getting that information, and that information is flowing from hospital A to hospital B, or from hospital A to the skilled care facility that the patient might be moving to, or vice versa, as that exchange of information becomes greater, there's probably going to be less need for patients to have to ask for their record, because the required information that they need to coordinate their care is already going to be flowing. Where we, I think, have to highlight for the regulators is the concern around what we have typically called in our industry, in the ROI industry, bad actors. People who are saying they're requesting the patient on behalf of the patient, but they're not acting on the patient's behalf for a healthcare decision. So even if you look at the interoperability rule, it says an attorney can serve as a patient representative and if they're making a healthcare decision. That and is a critical statement there. So since the notice of proposed rulemaking doesn't clearly define the definition of a patient representative, again, it was defined in the original rule. It's defined in the interoperability rule. It's left for open debate in this one, in this notice of proposed rulemaking. I would suggest that facilities call that out, that needs to be defined, that it needs to be a natural person. It can't be an organization that's got an economic reason to obtain those records. And the first time I heard the term natural person, I was like, that's interesting. But that's really what we're talking about. From a legal perspective, that's how they would define it, a natural person. So if it's a natural person that's actually helping to coordinate the patient's care, for example, like myself helping my 93-year-old mother, that's totally legitimate. But if somebody says, hey, I have gotten you to sign this and I've taken that signature and moved it several times, and now I'm asking for this so I can use it to obtain information for a trial attorney or another legal action, that's not helping to coordinate my care in any way.
So it seems like better definition under this proposed rule needs to occur in order to protect the privacy overall and the confidentiality of patients' private information by defining who that information can be accessed by and under what circumstances. It seems like I think that you have pointed out that the guardrails, I believe was the term, have been lowered, and it seems that this is, while trying to solve a patient access and being able to get that information as quickly as possible, it may have some reverse identification going on where it is in opposition of what it's actually trying to accomplish. Without that,
that's well stated, Don. I think that's what all of us in our responses need to keep in mind, is that we need to point out what the unintended consequences to this notice of proposed rulemaking might interject. Remember, the folks that are writing this rule don't sit in the kind of seats we do. And when I say we're specifically focused to health information and release of information. And you and I both have been in health information for many years. So they don't have the experience we've had from a departmental perspective, working in a healthcare organization, even to the ROI industry. And I think it's important that we help tell that story so that they understand that here's what you're saying, and the unintended consequence that might develop from that is this. And then helping to point out that clear rules and common terminology and concepts are going to facilitate compliance, and it'll reduce burdens to facilities. So we just really think that this is a perfect opportunity for people to read it, to read this notice of proposed rule, to react to it, call out that they feel that there should be complete harmonization to the extent possible. As you know, if it's possible to have these different areas of the government working together, which would be a novel concept, wouldn't it? One wouldn't say something and something else another area would say this. So that's the point that needs to be made. And we've been given a glorious gift by having the response date for this notice of proposed rulemaking extended by 6 weeks. It originally, the responses were due March the 22nd, because there was confusion in the industry with of the timing of when this was released. And then President Biden said he was putting a stay on things. A lot of people thought this was on hold. So they extended it 6 weeks because of that confusion and allowing organizations more time to read it and respond. So I greatly encourage the listeners to read the rule, respond to the rule. If you have questions, don't hesitate to reach out to me. I'll be glad to let you bounce off your thoughts onto me, and I'll share what I'm learning. But it is definitely a time that the industry and organizations respond, because this is our only opportunity. When they provide a notice of proposed rulemaking, they say, hey, here's what we're thinking. Tell us what you think. If we don't hear from you, this is what we're going to do. So this is our time to possibly steer the ship in a different direction of where we think it needs to be, what route it needs to be on.
Rita, if we were going to boil this down to our listeners for 2 items that would suggest that their response under this time period that we have to issue comments and concerns back as a part of this rule, what 2 concepts or thoughts would you suggest that they focus on?
Yes, Don, I would suggest the following 2. First and foremost, I think first, the erosion to privacy and looking at those areas where harmonization needs to occur. And we're going to share some of those concepts in our response letter and an insert that we'll be glad to provide to our listeners or to our customers as we're sharing this information. We also see that in this rule that there is definitely going to be a cost shift as it's currently written. And when I say a cost shift, the services in which many ROI vendors, respond and, we're able to do work, we're able to provide to the patient usually at minimal cost or sometimes no cost. It really depends on how the facility wants, but we're able to do that because of the ability to charge in a structured way by state rates and other rates that exist for other third parties. The notice of proposed rulemaking breaks down this charge structure that if it's electronic, it narrows it, and then it's a hybrid. It brings it to another level. So AHIOS, which is the trade association for release of information vendors, has commissioned an economic study to challenge the thought process behind the economic shift that we see. They call that out on page 88 of the notice of proposed rulemaking. They said, if you don't agree with our analogy, please tell us. So we are. We think that their analogy of what this does to the industry and the cost or the lack thereof is not being recognized appropriately. Because if your ROI partner cannot recoup their cost, either for them to do the same services that they're doing, they have to be able to assure a percentage of a margin or some kind of a way to charge for that. But if your facility can't accommodate that, your budget won't allow for that, or then you might have to consider, can you take that back in-house? And can you have the budget to take it back in-house? Would you have staffing to take it back in-house? Would you have staff trained to do it? So one of the things that we will call out in our response and using the AHIOS data is the schematic that they prepared several years ago about the various steps that are taken in the release of information process. And Don, I think you were in, a major part in helping to create that document, so you could probably speak to it better than I do. But it helps tell the story to the person reading the document. This is not as easy as pushing a button. So for some reason, the regulators have gotten into their head. Well, most medical records or health information departments now have electronic documentation. They have bits and pieces of electronic documentation. But they think, well, because there's 80% have electronic documentation, they can just go push a button. And what's the big deal? There's no labor involved in that. But there is labor because it's not all of the health information is in one repository. There's other repositories of information that have to be collated and pulled from. And that's the story that you've got to tell. I know one of our large hospital systems, Don, that we work with, they said they had 11 systems. I talked to somebody the other day and they said, well, within our system, there's 43 different systems. They're quite a large system and they've been buying and merging and, and as that happens, they don't all merge into one central repository, nor would they have the bandwidth to do that. So that would be the two areas that I think would be your top concerns is the cost shift analysis that should be considered and analyzed of what impact that might have to your facility, as well as the erosions to privacy that might be interjected by this proposed rulemaking.
I want to thank Rita for being my guest on the show today. For more insights on patients' medical records through the health ecosystem, visit the show's page at mrocorp.com and be sure to explore additional resources and thought leadership. You can also check out our program page on healthcarenowradio.com. Finally, be sure to connect with us on Twitter at MRO Corp. Until we talk again, I'm Don Hardwick.